Today we are discussing BCG vaccination. Introduction. Mycobacterium tuberculosis. The etiological agent of tuberculosis is an important cause of disease and death, particularly in the developing countries. In most developing countries, the existing strategies for control of TB is inadequate due to the rising number of drug-resistant strains. High cost of drugs are other socio-economic conditions. Primary infection often goes unnoticed clinically in the majority of those infected and may progress to cavitary pulmonary tuberculosis, extrapulmonary tuberculosis, miliary tuberculosis, or meningitis. The only vaccine currently available for the prevention of tuberculosis in BCG, bacilli calmette guerin, which was developed in 1921. BCG vaccine is effective in protection against meningitis and disseminated TB in children. However, it does not prevent primary infection and, more importantly, does not prevent reactivation of latent pulmonary infections, the principal source of bacillary spread in the community. Therefore, the effect of BCG vaccination or transmission of MTB is limited. However, BCG vaccination is considered a life-saving and important component of standard TB control measures in most endemic countries. BCG has protective effect against leprosy in the range of 26 to 41% based on controlled trials. However, BCG vaccine is not used specifically to control leprosy. A specific formulation of BCG is used in the treatment of superficial forms of bladder cancer. It mounts a local immune reaction against the tumor. In Sri Lanka, the coverage of BCG vaccination is 99%. Type of vaccine. BCG is a live attenuated vaccine which comprises M. bovis strain that calmette and guerin passed through numerous cycles. All vaccines substance in use stream from one source, strain bacilli calmette guerin. A number of BCG vaccine strains are available, although the French Pasteur strain 1172 P2 and Danish strain 1331, the Glaxo strain 1077 and Tokyo strain 172 account for the about 90% of BCG vaccinations worldwide. In terms of efficacy, no BCG strains is demonstrably better than another, and there is no global consensus as to which strains of BCG is optimal for general use. Efficacy. BCG shows efficacy in the range of 60 to 80% in non-endemic countries, but shows a much lower efficacy in endemic countries. However, the average protection against TB, meningitis, and disseminated disease is 86%. Due to this, childhood immunization with BCG has caused a remarkable reduction in the incidence of miliary tuberculosis and tuberculosis meningitis in children. Indication. In endemic countries such as Sri Lanka, vaccine is given at birth, including low birth weight babies and premature babies before discharge from hospital. Children between 6 months to 5 years of age without a BCG scar is expected to be present by the age of 6 months after successful vaccination. A tuberculin test is not required prior to vaccination. In non-endemic countries, vaccination is indicated for children and adults who are the risk of TB exposure and tuberculin negative less than 10 mm. Dosage and administration. It is a freeze-dried vaccine. One vial contains 20 doses. It is dissolved in 1 ml of diluent. Dose is 0.5 0.5 ml for infants and 0.1 ml for children over 1 year and adults. During administration of the vaccine should be exposed to light for the shortest period of time possible and never for more than 4 hours if it is not used immediately after reconstitution. The reconstituted vaccine should be stored between 2 to 8 and protect from light. Any vaccine remaining at the end of vaccination session, minimum 4 hours, should be discarded. The vaccine should be injected by a trained person strictly via a intradermal route to the left upper deltoid region using a fine needle gauge 27 1 centimeter in length. Administration of BCG to any other site is not recommended. Antiseptic should not be applied over the site prior to injection. Normal saline or distilled water can be used to clean the area. Contraindication: hypersensitivity to any component of the vaccine, symptomatic or asymptomatic. HIV disease: infant born to HIV positive mothers could be tested for HIV using HIV RNA test, and if results are negative, BCG should be administered. Congenital immunodeficiency disorders, malignant disease, persons under immunosuppressive treatment. Precautions: in cases where infants have been exposed to smear positive pulmonary TB shortly after birth, BCG vaccination should be delayed until completion of 6 months of prophylactic isoniazid treatment. Children with a family history of immunodeficiency disease should be investigated prior to vaccination. If they are vaccinated, and special should be